So we're back to continue doing this series that I'm calling Don't Believe the Hype. What I'm going to do here is take you through some information to attempt to let you know why I have a hard time with a specific muscle and the palpation of a specific muscle. The muscle that we're going to talk about is the piriformis. Now, I am over time attempting to build the case that identification of specific structures is much more difficult than we would often like to believe, and than we've been trained to believe in varying hands-on therapeutic professions. So I'm not sitting here trying to say that what you've been taught is correct or incorrect. I'm trying to show you why I have trouble buying what educators are often selling, or what the culture of these varying hands-on professions are selling. I am an osteopathic manual therapist. I do believe that I have quite a bit of positive impact on people that I treat, on the people that I provide care to, but I don't believe that I can identify absolute specific structures beyond a shadow of a doubt and then be very confident that that's the truth and then communicate it to my patient. I have a preference for leaving room for the reality that is identifiable, that there's quite a lot of possibility that most of what we say is not as accurate as we'd like. So again, I'm trying to build the case. I'm not trying to tell you that something's right or wrong. One of the things with scientific investigation is that if you do it appropriately, what you're able to do is falsify a hypothesis. So often what you may be attempting to do isn't necessarily to prove yourself right, but taking the steps to prove yourself wrong. And in taking the steps to prove yourself wrong or your hypothesis wrong, if it doesn't falsify it, then you gain confidence that you're closer to being accurate. The use of hands-on methods, of palpatory methods, to attempt to identify specific structures is not showing me over time that it's what it's cracked out to be or as accurate as we'd like it to be. So that's this mantra that I keep coming back to, not as accurate as we would like. Doesn't mean it's impossible, but when studied, when put under the microscope, when put under investigation, we keep coming up short as professions and as far as the accuracy that we claim to have. Now with soft tissue structures, they're soft tissues. They're subcutaneous, right? So they're below the skin. We're working outside of the body. Depending on where you are in the world, your patient may be completely clothed, they may be in varying states of undress, they may be in thick clothing, they may be in thin clothing. I can't speak to that reality. I can tell you that all my patients are fully clothed, often in quite thick clothing, and that's the way that it's working for me in my practice, in my country, in my culture. That's the way it's working. It doesn't mean that it's right, it means that it's the way I experience it. So what we're going to do here is we're talking again about the piriformis specifically. Now, the piece of research that I'm going to pull up first is really not about palpating the piriformis, it's about performing injections, because there's a piece of information in here that points towards some of the problems with identifying piriformis. So when trying to inject something into the piriformis muscle under imaged guidance, there are still problems. So this study is essentially comparing in a cadaver, right? So one of the limitations that these authors talk about within their write-up is that they were using cadavers and not live people. To compare the two imaging procedures to be able to accurately guide and inject into the piriformis, you would have to inject somebody twice, and you're going to have a really hard time with ethics approval, with the ethics review board, to get a study like that through, because you have to expose people to 2 injections, and there is a lot of opportunity for harm. So you're going to have a really hard time getting to that through an ethics board. You use a cadaver, and it may impact the outcomes to a degree. However, when you're taking an undissected cadaver and you're attempting to inject a specific structure, it's not likely that that's going to be an issue. These cadavers were also unembalmed, so you're not necessarily shrinking these tissues. These tissues are probably still very similar to what they would be like if they were alive. So that is a possible limitation of the study, but that's not necessarily what we're looking at. That's not the piece of information we're trying to take here. What we're trying to show is, or identify, not necessarily show, but identify to put forth as a part of the argument, is that even under imaging, there's problems being accurate with identifying and injecting, not palpating, but injecting the piriformis. So the name of the study is Accuracy of Ultrasound Guided versus Fluoroscopically Guided Contrast Controlled Piriformis Injection. So ultrasound guided, I think ultrasound imaging is understandable enough for most people. Fluoroscopy is essentially a continuous X-ray that you have. What you do is you basically have the continuous X-ray machine going, it's beamed to a television, and you move things, and that allows you to identify the relationships between them. So in the case of the piriformis, what you're probably looking for is the greater trochanter, and then the pelvic wall, or in this case probably the ischium. You're looking for the greater sciatic notch if you can find it on the fluoroscopy. What this study shows overall is that in this circumstances, with 10 cadavers and one individual injector, or one person performing all injections, that I believe it was 95% of the time the ultrasound guidance was accurate, and I believe 30% of the time the fluoroscopy was accurate. One of the other limitations of the study is there was only one injector. It was only one person who had been appropriately trained to do both of these procedures. Right? You don't have a wide sample here. It's hard to extrapolate this out to multiple injectors, but if you have somebody who's appropriately trained doing the same procedure with two different imaging procedures, you have a reasonable comparative. So that's kind of what we're looking at here. We go down to the highlighted portion here. This is part of the background information when writing up this study and giving some rationale for why they're trying to compare the imaging methods. What it says is originally piriformis muscle injections were performed blindly in the office by physicians. So we can find it, of course we can find it, here you go, here's the injection. However, because of the small size of the piriformis muscle, its deep location and its proximity to important neurovascular structures, the use of image guidance has been recommended to improve accuracy and reduce risk. One of the risks is that you may accidentally inject the sciatic nerve. If you inject the sciatic nerve with anything, you can have a lot of complications, not necessarily just motor, but sensory. You may have a lot of pain, a lot of complications. So this piece of information allows us to build into our argument, or into my argument, that it is well known that the piriformis is deep. It is not that large. It is not that easy to find. It's easy to, in a relative sense, triangulate between multiple structures based on attachment points, but it doesn't mean it's absolutely easy to find. We look at another study, and this is, if we go up to the top here, all the way to the top, this will take a minute. This study is the Piriformis muscle syndrome, an exploration of anatomical context, pathophysiological hypotheses, and diagnostic criteria, right? The thing that I want to pull from this is back where we had it highlighted, and I'll try to get there. It's talking about palpation, right? It's not easy when you're searching for diagnostic accuracy, or at least it hasn't been for me to identify a paper that really talks about the accuracy of the palpation. It talks about the accuracy of clinical testing, which are essentially orthopedic tests, which you're looking at motion characteristics, and you're also looking at pain production to diagnose as a proxy a piriformis syndrome. But to actually palpate it, this is one of the few descriptions I found. I found other descriptions that say the same thing. You know, you go to this point, you go to this point, it's on this diagonal line, 1 to 2 centimeters from here, right? So this will be in this description. During palpation of the gluteal region, and notwithstanding the presence of the gluteus maximus muscle, it is frequently possible to perceive an indurated and painful cord along the trajectory of the piriformis muscle. So what you're getting here is where you're looking, what you can expect to find, and the fact that it's going to feel like this. It's going to perceive an indurated and painful cord, right? So you're not perceiving the pain. If you poke an area and the patient says there's pain in the area that you think this muscle should live, then you're going to infer that it's this muscle, right? The way this is stated shows you that The diagnostic criteria is very much inferential. You're saying, well, it's in the area, it hurts, it's a cord, it's gotta be that. The challenge that I have with this is that even in the beginning of the sentence, based on superficial or based on positional anatomy, so superficial to deep, you have skin, you have subcutaneous fat, you have the gluteus maximus, then you have a bunch of other muscles that are deep to the gluteus maximus that will be obscured by gluteus maximus, by skin, by subcutaneous fat, and then you're going to say that you can accurately pick apart all of these muscles and say, for sure, I've got the right one. I have a bit of a problem with that, not simply because of the superficial to deep anatomical relationships, but also because of the variations in individuals. Individuals may have an overdeveloped piriformis for some strange reason. They may have a very small piriformis. They may have an underdeveloped gluteus maximus. They may have an overdeveloped gluteus maximus. They may have a lot of subcutaneous tissues. There's a lot of factors that give me the opportunity to believe that at best I'm making an inference as to whether or not I've accurately found the piriformis. Also, pain provocation does not mean I've found the thing. It just means in the area of the thing I think I found there's pain. That pain can be very superficial. It's hard to pick that apart because you're not experiencing the pain. The further description of how you do this, in a patient in a contralateral lateral decubitus position, the examiner places the hip of the painful lower member at 45 degrees of flexion and in light internal rotation with the knee propped on the examination table. Piriformis muscles palpated 1 to 2 centimeters below the middle third of a line drawn between the posterior superior iliac spine and the upper boundary of the great trochanter. So they're giving you a region, they're giving you a triangulation opportunity. But again, you're inferring things because in this area there are other pieces of anatomy, there are other muscles that will follow a very similar path and will have a very similar possible feel, right? Your gemelli, superior and inferior gemelli, are going to feel like cords if they're palpable. I don't necessarily think they're palpable in a reasonable fashion to be able to separate them from one another, right? But this common description, or fairly common description based on my experience, shows you that you're triangulating, you're using multiple landmarks to try to identify the region, and then 1 to 2 centimeters. That's not very accurate in the human body. 1 to 2 centimeters could be a completely different thing. If you're using 1 to 2 centimeters to find the gallbladder, right, or to find some other vital structure, if you're 1 to 2 centimeters off of the abdominal aorta, you have a problem, right? Your accuracy is not what you claim it is. 1 to 2 centimeters may be something that people have built into the description to say bodies are different, but again, this is a bit of a problem. This doesn't say that we definitely found what we wanted to find. This is one of the underlying reasons why I move away from specific identification of structures as a dominant diagnostic criteria and move more towards motion. If the motion isn't doing what it's supposed to do, and I can compare it side to side with the patient, then I'm more confident that I found something that I can appropriately intervene with, as opposed to finding a specific structure and saying that's definitely it, and then this is what I have to do. I'm going to look much more at motion. I can trust that better, especially more macro motion. Macro motion is more identifiable, more useful in that I can compare it more accurately than micro motion. Micro motion is less trustworthy. People will claim that they're very good, that their palpation is highly developed, and that they can definitely tell the difference between this thing and that thing by moving in millimeters. I again have a problem with that. I'm not saying it's impossible, but I'm saying that I just don't trust people who are saying that, because what they're essentially telling you is that they believe everything that they've been taught. They believe that they spent enough time to have a better developed sensory system than you do. I wouldn't say that they have a better developed sensory system. I'd say that the vast majority of sensory capacity to identify differences between things are already there. Your training and your experience may let you tune into it better. There is an argument that some people will make that you improve neural conduction along certain sensory pathways, and that very well may be true, but I don't think it makes you feel things that are hard to perceive. If they're hard to perceive because of the distance in which they're moving, they're hard to perceive for that reason. You may become more sensitive to it, but I wouldn't trust it. Your patient won't trust it if you only move millimeters and then you tell them they're better and then they stand up and they know they're not better. they're going to have a much harder time trusting you. So I tend to default to macro motion because it's easier to prove to me, it's easier to prove to you if you're observing, it's much easier to prove to the patient, right? So we go and we take a look at the actual anatomy to give us a slightly better understanding of this. Now this may not show up perfectly again, but we have a cadaver with skin intact but cut away in flaps. So up here in this flap that I'm going to try to outline, right, so up here we have gluteus maximus cut, G max. It would be folded over here, right, and it would be covering all of these structures. So you have, gluteus minimus, then you have piriformis, you have the sciatic nerve, obturator. Like, you've got a lot of structures in here that's under adipose tissue, skin, and the gluteus max. It's going to obscure it. You've got these tissues that are going to have multiple angles. You have a problem identifying this specific structure. Am I saying you can't? No, I'm not saying you can't. I'm saying it's difficult to do in a way that anybody observing you should trust. I'm saying that you shouldn't trust that you definitely have the piriformis, and even if you do, if you accurately identify the piriformis, how does that change what you do? How does that change the tests that are going to tell you how it's functioning? Palpating it and knowing that it's sore doesn't change the way that you're going to interface with it to change its function. Your motion testing tells you how it's functioning, how it's allowing for freedom of motion, how it's allowing for tension on the sciatic nerve, should that be the case. Whether or not it is doesn't matter. Identifying the structure doesn't change what you're going to do as a hands-on therapeutic professional to improve its function, to change its state. The motion testing does. The tension that the patient feels, the symptom provocation, whether you like it or not, that's what's going to show the patient a positive result, and they're the one that needs a positive result. Your palpation does not change what you're going to do. It might make you feel like a superhero, but you don't need to feel like a superhero. You need to help your patient. Your patient's the end user. So overall, what I'm trying to suggest in bringing this information forward is that if you're trusting specifically what people are saying about palpatory accuracy, it would be worth your time to reconsider. It would be worth your time to look at these things and consider whether or not somebody's just repeating what they've heard from what they believe is authorities from the past that came up with concepts 200 years ago, 100 years ago, when we didn't have images, when the level of evidence was looking at things from the outside. And if you're looking at things from the outside and that's all you've got, you're doing pretty good if you use certain palpatory triangulation methodologies. But if you have ultrasounds, if you have MRIs, if you even have fluoroscopy, if you have multiple ways to see inside, you start to know that you're not as accurate as you want to be. It does not benefit our professions to consider old descriptions as gospel when we have better methods to prove or disprove our accuracy. There's a saying that I heard very recently. There's a gentleman named Andy Stumpf. He was a former Navy SEAL. He has a podcast called the Cleared Hot Podcast, and he was going back and forth with some banter with a podcast guest, and he came up with this statement, or came up with this concept of the ancient art of bullshitsu. There's a lot of stuff that happens in a lot of professions. This is not exclusive to osteopathy. This is not exclusive to chiropractic. This is not exclusive to physiotherapy. There's a lot of stuff that is culturally embedded in many professions that's perpetuated, that falls prey to the ancient art of bullshitsu. If it is very unlikely that you can actually feel something, if it is very unlikely that you can identify something, but somebody says you should be able to do it, they ask you if you found it, you say, of course I have, because in a room of your peers, you don't want to feel like the fool that's going to challenge the orthodoxy. That doesn't mean that challenging orthodoxy is always intelligent. There's times when orthodoxy is correct. There's also times when what you're really falling prey to is the ancient art of bullshitsu. I would suggest that you try to develop the skills to identify when somebody's pulling the wool over your eyes, when somebody, or not even when they're pulling the wool over your eyes, when they are telling you information that they don't even know that is inaccurate just because it comes from a long line. doesn't mean it's correct. So I would suggest to you to start to develop those skills, to take a look at these things, to attempt to think for yourself. And I understand that in certain circumstances, when you're in a group setting and everybody's drinking the Kool-Aid, you'll want to drink it too, just so that you don't stand out and so you don't have problems. Your motivation may be, I will agree so that I don't have to hear the fallout. I don't have to be yelled at. I don't have to be singled out. I'll say yes. The danger in that is that if you just say yes and do not investigate when your radar is going off, you're going to have problems going forward. So hopefully this takes you through this concept. The commentary also hopefully fills in some more of my viewpoints. I want you to keep in mind, I'm not saying I'm right. I'm saying I'm building an argument for myself. I'm trying to highlight the process of building that argument. I'm trying to say that there are blind spots in my argument. There are things that I don't know. If you happen to have those things and I hear them, I'm happy to adjust my viewpoint. I do it consistently. And I think that there's benefit in you doing so as well. So hopefully this is helpful to you. And keep not believing the hype. Don't believe the hype.